Good morning and welcome to the 9th meeting of the Health and Sport Committee in 2017. Could I ask everyone to ensure that their mobile phones are on silent? It's acceptable to use phones for social media within the room, but please don't take photographs or record proceedings. The first item on our agenda is subordinate legislation. We have two negative instruments today. The first is the Personal Injuries NHS Charges Amount Scotland Amendment Regulations 2017, SSI 2017-58. There's been no motion to annul, and the Delegated Powers and Law Reform Committee has not made any comments on the instrument. Could I invite any comments from members? No. Is the committee agreed to make no recommendations?
Yes.
Thank you very much. The second instrument is National Health Service Payments and Remission of Charges Miscellaneous Amendment Scotland Regulations 2017, SSI 2017-59. There has been no motion to annul, and the Delegated Powers and Law Reform Committee has not made any comments on the instrument. Again, could I invite any comments from members? No. Is it agreed we make no recommendations?
Yes.
That's agreed. Thank you. Could I, first of all, remiss of me not to mention that there's apologies from Alec Cole-Hamilton this morning. Agenda item 2 is healthcare in prisons. And we have two evidence sessions this morning. Could I, first of all, welcome to the committee Beth McMaster, National Prison Monitoring Coordinator, Her Majesty's Inspector of Prisons Scotland, Teresa Medhurst, Director of Strategy and Innovation, Scottish Prison Service, Fiona McNeill, Head of Adult Services South, Prison and Police Custody Healthcare, Glasgow City Health and Social Care Partnership, Gillian Galloway, Head of Prison Healthcare, Custody and Forensics Healthcare, and out of hours NHS Tayside, and a representative for Perth and Kinross Health and Social Care Partnership, and John Porter, National Nurse Advisor, National Prisons Healthcare Network. Welcome to you all. We're just going to move straight into questions. Could I ask why, when we are quite far down the line from the healthcare being in the hands of the NHS rather than the prison service, why do we have such a difference in the healthcare provided to prisoners than we do to people who are not in prison?
If I could, convener, maybe start the response. I think the challenge around the transfer of responsibilities has been a significant challenge. I think the health and social care issues associated with the day-to-day provision of health and social care in the community are significant. Factored into that, the issues associated with the prison healthcare population itself. No two prisons are the same. From a Greater Glasgow and Clyde perspective, for example, each of the 3 prisons within the Greater Glasgow and Clyde area have different buildings, different premises, different levels of access to supports of a whole range of different requirements. So there isn't a... It's difficult to put a size and scale on the challenge. I think there are lots of examples of where we have gone to improve services to prisoners, and lots of different areas can cite examples in lots of different aspects of improvement, but there's still a long way to go. And 5 years feels like a long time in some respects and a very short time in others.
How long will it take?
That's not a question I can answer.
John?
Neil, I'm not too sure the statement's correct, and I say that because the care that this population that are in the prison environment received in the community, as far as I can see from research, they're a very underserved population in the community. And I think prison, unfortunately, serves an opportunity to try and start establishing the health needs of that very challenging population.
So you're saying that the service provided in prison is better than what people are receiving outside of prison?
I think there's an opportunity to start tackling that population when they're in the prison environment. I do think they are underserved in the community.
But are they better served in prison?
I think their health needs in prison are attended to once they're in the prison service. I don't think I could comment whether or not that's better or worse when they're in the community.
Yeah, Gillian.
I think just to echo what Fiona was saying around, there have been some quite significant improvements in a lot of the establishments across Scotland, and that is demonstrable in terms of the way that some of the through care works for prisoners on release, in terms of giving equitable access, not just equal access to services whilst they're in prison, to meet their, as John says, quite a complex and needy group of prisoners and patients when they come into the establishments. And it does give us that opportunity to work very closely with them, along with the Scottish Prison Service, to meet all of their needs, not just their healthcare needs. So I think there have been improvements, quite significant improvements, in the last 5 years.
Who leads on this issue? Who leads on this in Scotland on prison healthcare?
So there's the National Prison Healthcare Board, the Network Advisory Board, which was chaired by Adrina Adamson. So that serves certainly that's both NHS and SPS representatives, and that provides some of the direction. John.
Yeah, sorry.
The accountability for prisoner healthcare, the delivery absolutely sits with the health boards. The network was put in place to ease the transition in 2011 and to support health boards, Scottish Government and other agencies. Whether or not it leads, I think is debatable. I think it provides a valuable service in terms of practice. It has a work stream associated with it, it has a work plan that looks at the risky areas around prisoner healthcare. And so it provides that support and advice to a host of agencies.
Who's driving or who's leading this at government level?
I would find that difficult to give you a named person. I think following the departure of the NHS Director for Health and Justice, I would be struggling to give you a single policy lead from Scottish Government.
Does anybody know? No. Okay, thank you. And do you want Alison?
Yes, thank you. I think one of the panels suggested that no two prisons are the same, and I appreciate that, but is there a recognised workforce model for healthcare in prisons?
There isn't actually. One of the groups, the NHS board leads, get together to look at sharing best practice and come up with a work plan. One of the work plans that the board leads has in place is to look at workforce. So there is an intention and a new work stream looking at developing a national workforce tool in liaison with Scottish Government colleagues who lead on planning workforce models.
Okay. Can I ask then, how can budgets and services be directed to improve prison healthcare?
So in terms of, from a Tayside perspective, we looked at the workload tools that were, workforce tools that were available, along with professional judgment. So with our nursing directorate, we worked very closely with them and the head of nursing for prison healthcare within Tayside to look at, from a professional nursing perspective. We also involved pharmacy and GP, so that it wasn't just nursing, it was a multidisciplinary approach to looking at the workforce modelling. The majority of that was done on professional judgment because there isn't a national tool, but we looked at the professional judgment, we looked at tools that were available both for acute wards, for emergency medicine and for community nursing as well, and we adapted them to look at it from a Tayside perspective, and we did come up with a baseline establishment for that.
Does anyone else have a comment on that?
I would just echo the approach that my colleague has just outlined. We have a professional nurse advisor within NHS Greater Glasgow and Clyde, which was one of our developments when we assumed responsibility, and that post holder crosses over police custody and prison healthcare, so there's some continuity. We've taken the advice of that individual around looking at what appears to be need on a day-to-day and ongoing basis, and adapted what tools that are available to us generally to use, but professional judgment is much more the order of the day in the absence of a validated workforce tool for prisoner healthcare.
Okay, can I ask another question, Convener? Last week we spoke with ex-prisoners, and one of them suggested that when he first went into prison in 1984-85, he felt that prison was full of criminals, and on subsequent occasions when he'd been in prison, that he felt it now often that some halls looked like mental health wards. And HM Inspector of Prisons noted, and I'm quoting now, frustration that people with mental ill health are in prison when a hospital setting would be more appropriate but not available due to a lack of beds. I just wondered if you could tell us what steps are being taken to ensure that people aren't imprisoned inappropriately due to a lack of services out with.
Question. I'm not sure we can answer that. I mean, I think those that deem prisons to be the safe environment, so a sentencer will place, I think, and it's a personal statement, this will place someone in a prison environment with a mental health condition because it's a place of safety. That doesn't strike me as a health professional that we have it right in the community. I'm not sure, and I wouldn't support that those with mental health challenges in prison should, on the opposite side, be in a hospital environment. I think resources within the community to support people and reach them at a stage where they are becoming unwell, but unwell before they reach prison. And if it's the only option is to place someone in prison because it's a place of safety, I think is an indictment in Scotland's approach to those with mental health.
I think in terms of the actual placement of the prisoners, that's obviously not sitting with health. I think what's important for us is that if those health needs are identified, that there's clear pathways in place for them to access the care that they need, whether that is provided within the establishment or whether that is out with the establishment.
A prison's perspective, anecdotally we have information that comes from courts to suggest that sheriffs sometimes, on occasions, feel it necessary to place someone in custody for their safety. It happens probably more frequently with women than it does necessarily with men, anecdotally. The other area is that sometimes they're put into custody for assessment purposes. And they will get those assessments within our establishments. But I think, as Gillian has already pointed out, when somebody comes into custody and it's clear either on admission or very shortly after admission that they have acute mental health problems, we will all work together to support their placement in a more appropriate setting so that we can move them there as quickly as possible. But I think it's variable across the country.
Can I just ask one more question? What would a more appropriate setting look like? And is that more appropriate setting always available?
Well, a more appropriate setting would be a mental health facility as opposed to a prison facility, because obviously prisons are designed for locking people up as opposed to treating them. And there are certain restrictions, therefore, on what type of support can be offered within a custodial environment as opposed to a psychiatric facility.
So if you had concerns, you would take action to,
yes, absolutely,
to have the prisoner moved?
Yes.
Okay, thank you.
Do we know what percentage of the prison population have mental health problems?
There's various data around.
Is any of it accurate?
It's accurate in terms of the time it was published, but you're talking probably 70% of the population.
70.
70% with a mental health challenge.
Okay. Miles?
Good morning to the panel. I wanted to follow up on Alison Johnson's question there with regards to the research you're doing around this. So what research have you looked into with regards to the relationship with mental health and reoffending within the prison population? Especially given that in many cases we're seeing that cycle of reoffending. To what extent do you think that's not really being addressed?
I'm not aware of any specific research that is looking at reoffending rates coupled with mental health and that move from custody back into community again. There has only in recent years been research in relation to trying to quantify the level of personality disorder within the population. Certainly when I was at Corton Vale, that's work that we did there, but there's nothing specifically around about reoffending rates that I'm aware of.
Certainly the mental health work stream, one of their recommendations was to look at undertaking a mental health needs assessment for the population. That was the recommendation. That hasn't been implemented as yet, and there is efforts to try and source the funding that would enable that research to take place.
Another area I wanted to look into, I've been struck by the number of people we've met who have, in terms of professionals in the prison setting, who have said head trauma for individuals has been a major issue which hasn't ever been addressed early on. And what sort of work's being undertaken within the prison service to look at that and how potentially support can be provided?
Yeah, there was a request from the Justice Committee to undertake an examination of brain injury in prisons, and there was a work stream secured, and Professor Tom McMillan led that work stream on brain injury. That report has now been published, and with a whole host of recommendations, which I hope you won't ask me to name, but that's a concise piece of work, evidence-based, and I have to say from a very reputable chair.
I have one final question. Another area which I've been quite shocked about is actually professionals saying, online records is a major issue which is preventing them being able to really improve treatment for the prison population and actually following patient records. Is that something you've tried to improve yourselves and had pushback? Is it a budgeting issue? Because it seems something very simplistic which could make a huge difference.
I didn't quite understand that question.
In terms of online patient records being developed at the minute, most professionals we've come into contact with have actually complained about a paper trail and not being able to really focus on individuals when they're in a prison setting and actually they're through care, especially then when people are leaving prison and registering potentially, and that information being passed on to a GP or another professional.
I can speak to that. I'm sure Fiona will probably want to come in as well. I think, yes, clinical IT is an issue for, I think, everybody that works within prison healthcare. There's one, it's called GP Vision, and it specifically covers all of the establishments. What that doesn't allow us to do is when prisoners are admitted to a prison, we don't have access to their GP records from the community because it's a different GP Vision system that the GPs are using. So in terms of that kind of transition and through care back into the community, that is a significant challenge for us, and we all have to have kind of local solutions to that as to how we work with our own primary care services to make sure that that transition is as smooth as possible for the patient on liberation. I think there's the national work that's ongoing around the GP reprovisioning. Unfortunately, the prison side of that isn't part of, and it's out of scope for the national GP reprovisioning programme. And I know certainly through John and Tom that they've been working quite hard with the Scottish Government around kind of clinical IT systems for prison healthcare. But it is a significant challenge, along with the fact that we can't electronically prescribe. So in terms of all the prescribing and administration of medication, it is on a Cardex, which is challenging as well for the number of patients that we medicate.
If a prisoner comes in, if a prisoner went in today and had an immediate health need, you cannot access their patient records.
So what we can access is called the emergency care summary, and that has kind of key information for that patient on it, but we can't access the records from their own registered GP.
So does the GP guess, the health professional guess what's wrong with the person?
There's an admission process that they'll go through on admission. So initially they're seen by a nurse who goes through quite a detailed admission process with them.
That person might have mental health problems. They may have, substance issues. They may have a whole range of issues that means they are not coherent or can't remember or whatever.
At that point, if there was any acute concerns by the nursing the professional nurse that was doing the admission process, then they would seek the support from a GP at that time.
Who would then be able to access the records?
They wouldn't be able. We can't access. If there was any specific questions, then they would have to then be phoning the GP practice rather than
Which might be closed.
accessing it. Sorry.
Which might be closed.
Might
May be closed at that point.
It might be, yeah.
So
So all
it's-
that we have is the emergency care information and whatever's on clinical portal, which some key information is on as well.
So that's a huge gap in the system.
Yeah, it's a significant challenge.
Okay, Claire.
Thank you, Convener, and thank you, panel, for coming along today. I just want to take it a bit of a different direction, if I may. One of the written pieces of evidence that the committee got was from the British Psychology Society, and they noted that there needs to be necessary collaboration between different agencies operating within prisons, including the NHS, Scottish Prison Service, and the various third sector organisations in terms of delivering healthcare. And this was an area that was also raised with us from healthcare professionals when we sat down with people who actually work in the prison service about the different cultures and the different cultures coming together, Scottish Prison Service and NHS. And I wonder if the panel might comment on how they've seen that progressing over the last 5 years and the areas where we still need to see improvement.
I mean, I think that's certainly something that we notice frequently in terms of inspection and monitoring, really in order to make the most of the opportunity to provide healthcare in prisons. It's important that all the pieces around the table work together, and I think where there's a clear shared vision and clear shared joint leadership around about provision, that's where we see things going well for prisoners.
I think certainly over the years, because colleagues worked jointly prior to the transition anyway, there's been that continued positive working relationship at a very operational level. Occasionally there can be operational difficulties either on the NHS side or on the SPS side that can hamper relationships, but I think that we're all very clear that healthcare is such a significant issue. The complexities around the population that's now coming into custody in terms of their healthcare needs, not just around mental health, which has been described, but the addictions issues that the individuals are coming in with, social care needs is increasing. The age of the population, it's a much more elderly population than we've had previously. So I think all of those complexities together mean that it's much more of a priority for all of us within prisons, and we work very hard, but there are obvious differences in terms of, for a prison service, we're there to ensure that we manage the criminogenic needs of individuals as well as the healthcare needs, and obviously for the our healthcare colleagues, they're working in a secondary setting. So there are operational challenges and difficulties that we work through together, but I think the point that was made earlier about the relationships is absolutely critical and key, and at an operational level, generally those relationships tend to be very positive.
It's interesting that you say that, because we heard evidence that up to 50% of appointments are missed due to prisoners not being taken to healthcare facilities within the prisons. We heard evidence of prisoners not being able to access outpatient appointments because there had been no escort had gone there for them, that there's inefficient use of healthcare facilities within the prisons because of the interplay between having to transfer prisoners from halls to healthcare settings. So I'm interested that you're saying it's a priority, but it doesn't sound from some of the evidence that we've received that actually SPS is prioritising this.
We absolutely see it as a priority. If we cannot meet the healthcare needs of individuals, then we know that they can't be supported into working with us around about their criminogenic needs. They need to be healthy and well to be able to do that. So it is a very clear priority for us within the organisation. I think I'm surprised to hear you say that 50% of appointments are missed. I really welcome you sharing that information, because it's not information that I actually have. What we do is we work with our colleagues where we know there are difficulties. So, for example, in Grampian, when the inspection report was published there and there were clear difficulties there, we set up a strategic workshop between ourselves and our NHS colleagues and developed an action plan to help to support improvements. But prisons are very complex environments. There are a number of competing demands that we have to work to, and we need to ensure that where there are difficulties and issues that we work together to resolve those. And as I say, I'm not quite sure 50% because that's not something I've heard previously.
That for you, that what we were being told was about 50% of clinical time was not being utilised.
Oh, right.
Not 50% of appointments, and my apologies if that's what I said, but about 50% because clinicians were waiting for prisoners to be brought for appointments to see them. So it was a really inefficient use of healthcare staff time, which is obviously finite.
Oh, absolutely.
Sorry, just in addition to that, and to support Claire's point, in addition to that, they were spending huge amounts of time investigating complaints as well.
The complaints side of it is obviously an NHS issue. Medical complaints are no longer dealt with by us. There are, for example, if I can give you an extreme example, but it is an example, Edinburgh Prison has got 6 different population types within it. So you've got women, you've got remand prisoners, you've got long-term prisoners, short-term prisoners, you've got non-offence protections, and you've got sex offenders. So it's a very complex establishment. There are populations within that establishment that can't mix together. So therefore you have to take people for appointments at times when it's safe for them. You couldn't have women in the health centre at the same time as some of the other populations. We try as far as possible to reduce those operational difficulties, but where you have got those kinds of complexities, then there will be unfortunately an impact on those that can access services and how that's managed.
Something new? Is that a change to Edinburgh Prison population?
Edinburgh's had that population mix since 2011, I think.
So 6 years ago?
Yeah.
So why hasn't a system been put in place that makes more efficient use of the healthcare staff's time?
I think it's because of the way that it operates, that because you have to keep the population separate.
But that's why I'm asking why, if that's the givens, then why hasn't a system been put in place that effectively uses the healthcare staff's time?
As far as I'm aware, the establishment will be working to that on a day-to-day basis. So the approach that's been taken should maximise the amount of available time there, but there will be operational difficulties from time to time, which will mean that the position deteriorates on occasions. But where we are aware that there are issues and difficulties, we manage the clinics and the support that we provide, because when the last population to go in there was the women, additional staff, operational staff were put in to be able to support their attendance at appointments. So where we know there are potential difficulties, then we will look at the resource requirements in order to be able to better manage that.
But, let's be straight here. The staff who are working in your establishments are telling us there are huge problems in this, and they are spending lots of time not on clinical work because they're hanging around or they're answering complaints. And the prisoners who are within your establishment or have come through your establishment are telling us that they need healthcare and they ain't getting it because the staff are spending lots of time doing nothing. That's an issue for your organisation and has been an issue for some time, and we're not seeing a lot of evidence that that issue is being resolved.
I think two things. The issue about complaints I can't comment on. The issue with regards to downtime, there are times when clinicians will not be able to get access to individuals because of things like meal times, and other types of activities that are going on within the establishment. If somebody's going to a visit, for example, they will have to attend their visit with their family. So there are other things which happen, which means that there are competing demands within a prison. and it does mean that at times there is downtime for clinicians, but those routines have existed in prisons for some time, and it's about making sure that all sides are working to achieve a better outcome. Where, as I say, for example, there were issues and difficulties in Grampian. As I say, we held a strategic workshop between ourselves and the NHS, and we looked at an action plan. So if there are other areas that we require to do that, then we absolutely will work with NHS colleagues to make improvements.
Gillian, are you getting what I'm saying? Are you getting that back from your staff? Because I'm looking at the area you represent, and it was some of your staff who were raising this with us.
Yeah, so I think in terms of, there is a lot of work that we are doing locally with our SPS colleagues locally to improve the efficiency of the health centre clinics. I think in terms of downtime that they have, I think we're limited in terms of when we can access the patient. So we've got 2-3 hours in the morning and then the same again in the afternoon to actually have direct patient contact.
Why is that?
Sorry?
Why is that?
That fits in with the SPS regime.
Is the SPS regime wrong then?
I think there's a work that SPS are doing at the moment in terms of looking at the actual day within SPS, and they're engaging with NHS colleagues around how that can improve for both SPS and for NHS in terms of accessing patients. So we are limited in terms of the times that we've got to see patients, which is different to in the community.
So out of a 8-hour day that the average person, clinician would work, the maximum is a 6-hour window, and there's potentially a 4-hour window.
In terms of direct patient contact, but there are other clinical duties that they have to do in terms of looking at kind of cardex and prescribing and other clinical duties that they do that don't need direct patient contact.
Okay. Donald?
Yeah, just following on from that, it seems to me that the relationship between NHS staff and SPS staff is the crux of this, and that has to work, and it has to work at every level. What do you do to bring these two cultures together? What do you train? Do you work together? I mean, could you give the committee some idea of what is done on the ground?
Yeah, I'm happy to take that. In terms of from a Tayside perspective, we've got quite a clear process in terms of engaging with SPS. So we have a kind of higher level meeting with both governors of the two establishments that we have within Tayside, and part of that is around looking at kind of direction, vision, where we're actually going. Then there's an operational meeting whereby the head of nursing and the head of offender outcomes and deputy governor meet to discuss any operational issues, so that there's clear escalation from that if there is anything that we need to support. But also the team leaders and some of the nurses work very closely with the first line managers and the unit managers within each of the halls, and that's quite a new thing that we've put in Tayside, just to try and improve that relationship, so that I think there's an element of SPS understanding what the NHS have to do, and the NHS understanding SPS and the constraints that come with that.
Okay, but what if the issue is very personal and a prisoner says to the SPS staff that he or she knows best, I've got a problem with my healthcare. Are you content the relationship exists between that person and their equivalent NHS nurse or whoever it might be that might be prescribing or at least providing medication? Are you content that relationship?
I think in terms of the relationships that they have with their personal officers and the relationship that the officers have with healthcare staff, I'm certainly not aware of any issues whereby they have felt that they couldn't approach healthcare staff, and they do also, obviously we've got the independent monitors as well that come in and act on behalf of the patients as well, and certainly liaise with healthcare, and we work very closely with them if there's anything that we need to address.
In relation to staff, usually there are designated staff for particular halls, designated healthcare staff, so that relationship then is built up between the staff member and that particular hall staff, so that they've got a developing relationship over a period of time, and more knowledge and understanding of the individuals within their care. There are a number of our processes within SPS, so our case management processes, our risk management processes, which involve input from our NHS colleagues. So they have direct input to how we case manage individuals throughout their time in custody. And I think the other area is training that you touched on, and there are a number of areas where our training is delivered to all colleagues who work in prisons, which would include NHS colleagues, but there has been some training over recent years, more specific in some establishments round about mentalisation, personality disorder, which has been joint NHS SPS led and delivered to colleagues across prisons. So I think that as far as we can, we try and integrate as much as possible and develop that shared understanding.
But that should eventually, or should be, in a way, overcoming the operational difficulties that you spoke about when being questioned by the convener. And
I think, I mean, a prison has got to, you know, dine 3 times a day, so we have to provide individuals with meals 3 times a day. We've got a legislative requirement to provide an hour's exercise every day. In addition to that, we have to operate and make sure that people have got clean bedding, clean laundry, that they've got enough kit and equipment, that the prison is cleaned. So there are a number of functions that a prison has to undertake during the course of a day, which means that the time allocated for things like access to medical care is constrained because of the time that it takes to provide those things to the, you know, quite a significant population.
Can I ask one?
Yeah.
But this is changing tack a bit, but I think... Sorry.
I think some of the people wanted to come in on that point. Yeah. John and Beth.
I think Teresa touched a really good point. I mean, I think it's absolutely crucial that the efficiency of officers, you know, is paramount to the time that clinicians get to spend with their patients. And I have heard on a number of occasions from healthcare colleagues, healthcare managers, board leads, around where it works well is where there is dedicated officers to the health centre. Now, I'm not sure, and I apologise if that's... I'm not saying how SPS should operate, but I do hear it works better when there is a known body at the health centre, and it tends to be slicker and more efficient and less wasted time on waiting about. But I think Teresa, absolutely, I know the SPS are keen, you know, to work with healthcare colleagues and trying to deliver that degree of efficiency. Beth.
I think in terms of that point about relationships, we absolutely do see some really good examples of things that work really well. What we don't see as an inspectorate is consistency in that nationally. And there's a real question for us about how some of those good examples are rolled out on a national level. So while we think absolutely those relationships do exist in some areas, we see them working less well in others. Can
you tell us why? Is there any...
I think that's really hard for us to answer, and it's probably more appropriate for my colleagues here to answer that question. But I mean, I think it's about communication, and it's about, again, as I said at the start, leadership. So
I've got a slightly specific question about the healthcare assessment, which I think you said that every prisoner receives a healthcare assessment. And are you content that is being done to a satisfactory level in every prison, with every prisoner?
On every prison, but certainly within Tayside, and I'm sure Fiona will comment from a Glasgow perspective that the admission process is quite a robust process that they go through to help identify any healthcare needs, whether it's mental health, substance misuse, also accessing kind of some of the national screening as well. So it is a robust process that they go through.
And I would just echo Gillian's points. I think there has been work to refine the process over a period of time. The questions that are incorporated in that process might look slightly different now. We might need to do a wee bit more work around issues from a Greater Glasgow and Clyde perspective around the mental health questions we ask, and we're having a look at that for ourselves at the minute. But I think it's in the context of a robust process that could have some areas made a bit better.
Okay, Marie.
Thank you, Convener. I've got a number of questions in a number of different areas, so forgive me if I dot around a wee bit. Firstly, I wanted to tease out a little bit more information about this anecdotal evidence we've heard of people being sent to prison as a place of safety. So I've heard that a number of times when I've spoken to folk working in prisons, and I heard it again in the evidence gathering sessions that we held here. So people with very chaotic lives, possibly with personality disorders and addiction difficulties, prison is sometimes by the sentencer considered preferable because it takes them out of the chaotic situation that they're in. Yeah, I wonder whether that maybe underestimates the harm caused by prison, and whether it also shows a lack of understanding of the sort of more modern. I've been struck throughout this process that what happens on the outside in terms of treatment of addiction and treatment of personality disorders is very recovery orientated, and that's almost impossible to deliver in a prison institution, which is essentially institutional and punitive. And I just wondered if you could give me your thoughts on that, and perhaps some thoughts on how we might consider tackling that particular problem.
I think that I wouldn't really want to speak on behalf of sheriffs and people further up the criminal justice chain than prisons, but very often people who are chaotic have failed to engage with the criminal justice system, and I think sheriffs sometimes get to a point where they're quite frustrated over that lack of engagement. And you know, coming into prison does stabilise individuals in terms of they will get 3 meals a day, they will have their health needs identified and dealt with, because generally they don't tend to be people who have engaged with healthcare in the external environment. So I think that when they do, and I have seen from an operational perspective when I was a governor, you can see individuals over that first 2 or 3 weeks starting to improve, both in terms of their understanding and knowing where they are and what's happening to them, as well as just looking and feeling much better, and therefore better able to engage with services and better able to understand what needs to come next. I think in terms of recovery, that's probably something that I would leave to my healthcare colleagues, although we do in prisons try to work very hard with healthcare colleagues around recovery, and there are a number of good initiatives across prisons in relation specifically to addictions and developing work around about personality disorder.
Yeah, I think your assessment's spot on, and I agree entirely with what you said. Recovery and all these terms been bandied about. Sentences placing people in prisons. No, damage is done, severe damage to some of these individuals, and recovering from that. I'd be careful there, because they're generally in prison for a short space of time. What can we do with that population to make them recover? They're very quickly going back into that chaotic lifestyle. So for me, it's actually way upstream. Scotland isn't particularly good at challenging health inequalities. No, we've got a dreadful record. I think the model is wrong. I think in terms of that population, their needs, we need to go way back. It's early years, it's good parenting. So I think the effort should be about preventing people coming in to prison during their early years, because you can see it's a postcode lottery. We can identify those individuals that are likely to come to prison. Now, I know it's a bit theoretical from me, but I think Scotland needs to have some sincere thoughts around the model in which we occupy that kind of population.
And just to build on what John says, absolutely prevention is important. But if we do get the opportunity in prison to engage with people and get them on the right track, what's really frustrating is that they then often return out to exactly the same situation that they came in. And so all that potential and all that work is really lost. And from the inspectorate's perspective, that's something that really needs to be tightened up. So where there's good work, in theory, the transfer should have enabled us to do more in terms of keeping that going. And again, we don't always see that.
I think just in terms of the new community justice planning partnerships as well, I think that gives us a really good opportunity to build on that and make sure that the through care, so whilst we're working very much towards recovery and rehabilitation whilst they're in the establishment, that the pathways for them going back out in the community should be there to support that and hopefully try and keep them off of that chaotic lifestyle. So I do think that gives us a really good opportunity to make a difference.
Okay. The other thing I wanted to ask about is, we had a look at this inspection of a prison, and there's lots of points where you highlight good practice that's worthy of sharing. And I wondered how that process happens.
I think that's a really good question, and something I think potentially nationally we could build on. There are structures and routes for sharing good practice, for instance, with the kind of Health Board Lead Network and the National Prison Healthcare Network. But I think it's safe to say that we do see positive practice and we do comment on it, and we don't always see that being transferred to other places. And we understand that's in part about the complexity of different prisons and different populations, and also of course about different health boards' relative scope to prioritise prisoner healthcare. But at the same time, I think there's definitely a quick win there.
The Chief Inspector of Prison produces an annual report each year. Certainly in the last 5 years, I've produced a summary of the health component parts of that and shared it with all the prison establishments, including the SPS. Haven't done it this year, so thanks for that.
Okay, and the final thing I wanted to ask about is this issue of data sharing. So we've identified that you guys are pretty much in the same boat as, say, an A&E department, or where I used to work in a psychiatric hospital, in that you cannot access GP records. What you can access is the emergency care summary, which gives you a bit of information about current medication and past allergies, things like that, but it's not particularly detailed. So it doesn't tell you anything about the diagnosis, just simply the drug treatment. Another issue that's been identified by lots and lots and lots of people that we've spoken to is the need for electronic prescribing and administration systems. And this question about whether medication has been administered seems to be a source of huge conflict within the prisons. Would that also be a quick win? Although I know that electronic systems are not particularly straightforward, but would that be very high in your priority list as well, of something to do to improve?
Absolutely.
Yeah, I think unanimously, from a health perspective, it's absolutely one of the things we would want to be able to progress more than we have been able to do to date. And it's one of the things we think has the potential to give big gains to the delivery of healthcare, both in terms of the effectiveness and the safety issues around all of that, but also just in terms of that holistic approach, having as much information available as possible on which to base decision making, and to reduce some of the areas where undoubtedly there is conflict.
I mean, I have to say, I'm looking at information here. Some of this information the National Prisoner Healthcare Network have raised about IT for 5 years, and presumably everybody's moaned about IT for 5 years, and nothing seems to change. Why does nothing change in something as fundamental and basic as getting a bloody IT system that works?
Neil, I assure you, I think everyone round the table and the back of me are really frustrated with this too.
So who's responsible for fixing it then?
Yeah,
if it's no you, who is it?
I think we do need some strong Scottish Government policy lead to take a lot of these issues forward. The clinical IT has reached, e-health and those advisors in the Scottish Government to lend support, and I think it needs that. And unfortunately, it's taken a long time to reach the eyes, the ears of people that will enable those IT systems to take place. It may sound an excuse, but it's been a frustration for all of us around the table for many a year prior to the transition also.
And is that the same with a whole number of the other work streams that the National Prisoner Healthcare Network have been working on, but that do not appear to have been implemented? Are these pieces of work done? They're then fed up the line, and nought happens.
To a degree, yes, particularly those that require finance.
Is that the experience of others?
I think in terms of...
Teresa, sorry, you're nodding yes.
The board doesn't have any direct authority to implement the recommendations, and they
So
have
who
to
does?
go. Well, they have to go to the health boards, and it's for the health boards to then prioritise that within their funding.
Same experience?
Yeah, I think, and certainly within our experience in terms of prioritisation, we've got a clear process to go through and do get support from both NHS Tayside and the IGB to support anything that we need to do.
But you've not got an IT system?
We don't in terms of IT, but that's a national issue.
And I think that would be my point. The IT issue is a national issue.
But there are other national issues as well that you're frustrated with, that somebody is not making a decision to fix. Yes, no?
From time to time.
Okay, sorry Marie.
Can I just ask for clarity's sake, is there an off-the-shelf system out there that would give you electronic prescribing administration, or like many of the hospitals in Scotland, does that not actually exist? It's not simply a financial issue, is it? There isn't actually a tailor-made package there. Is that correct? Does anywhere use an electronic prescribing and administration system that you guys would like to use?
I think in terms of the general GP vision, that obviously does do...
That's not an administration system, that's the problem.
Yeah.
Yeah?
Yeah.
So you don't have an off-the-shelf package ready to use?
Not that we're aware of, no.
So it's not a financial issue, there's something needing to be developed, yeah?
Colin.
Thanks very much, Convener. Can I move on to a subject I think Teresa touched on earlier, and that's the issue around older prisoners. A number of the submissions that we received highlighted that one of the key challenges over the next 15 years relates to the fact that we'll be dealing with a lot more older prisoners with a lot more complex health and care needs. I think the Care Inspector at BMA, RCN and Royal Pharmaceutical Society all made this point in their submissions. So can I ask the witnesses what are the key pressures that the service will face as a result of an ageing prison population, and do you consider that these challenges are currently being adequately met and will be met sufficiently in the future?
I'll go first. I think, first of all, an older person in custody, we recognise that an older person in the community is generally over 60, whereas it's 10 years less in custody due to the health issues that are presented. The statistics do show that we are receiving more prisoners over the age of 50. And that is likely to increase due to the historical sexual abuse inquiries. What we have been doing is working with health colleagues and with local authorities on individual cases as the more complex cases when they come into custody. And we've also undertaken recently an assessment which isn't yet ready for publishing, but we've undertaken an assessment to help inform our strategy over the next 3 to 5 years, so that we're very clear about what we should be prioritising in terms of actions, because we know at the moment that we have difficulty accessing particularly social care for individuals. There's also sometimes difficulty accessing equipment. And there has been a considerable amount of money that we've had to spend ourselves on ensuring that individuals have got appropriate care whilst in prison from social care providers. And unfortunately, on occasions, even though it's not part of the remit, our NHS colleagues, where we have had acute cases, have had to step in and assist us with particularly acute cases where we can't access social care within the community. So there's a lack of clarity over who is responsible for social care in prisons, and we weren't included as part of the legislative changes. So in one or two individual cases, we've had to accelerate decisions up to chief officer level in order to get agreement on who's responsible for taking forward social care support for individuals whilst they're in custody. So I think going forward we see it as an ever increasing problem, and actually the evidence that we have so far shows that there's actually a proportion of the population with social care needs that are under 50 as well. That there's it's across the range of ages, and we would welcome some clarity over, as there are in other jurisdictions, around about who should be responsible for the increasingly complex needs that individuals require support with once they come into custody. Because, as I say, it's not an NHS issue, and that's very clear from our Memorandum of Understanding, which was signed in 2011. Well, that
clarity. Is it? You're saying you talk about legislative changes. Is that the integration change, or?
Yeah, the IGBs, yeah. It wasn't included in that legislation, so social care in prisons wasn't referred to. Therefore, it's not clear whose responsibility. So at the moment, we will access, where we require it, we will access agency support and pay for that for individuals in order to ensure they're getting the most appropriate care whilst they're in custody. But there is a lack of even agency support within Scotland just now. Therefore, we have to try and work with our colleagues within the NHS, and they have stepped in with some quite challenging cases in order to provide us with the appropriate levels of care.
Can I just advise, colleague, Macmillan Cancer Support have a very close liaison with prison service. I know that the SPS are working with them. NHS Forth Valley are working very closely with them, particularly aligned to that population in Glen Oakle, who are certainly an extremely elderly population. And they have adopted or adapted standards to support that prison environment. And I believe they've appointed a professional lead, I think just in January of this year, to assist in driving some of those standards forwards, hopefully from a national perspective rather than just containing it to Forth Valley and Glen Oakle. So good work in progress.
Sorry, I'll bring Ivan in first and then we'll come back.
Thanks, panel. I just wanted to touch on a couple of issues that have kind of been covered to some extent before, mainly about kind of through care, and just understand that in a wee bit more detail. So, the point of release, can you just describe what the process is for making sure a prisoner or an ex-offender is then registered with a GP, has access to other medical services that they may need, information is passed on, and then I know it's not in the scope, but wider issues like housing, etc., which obviously have an impact on health. What does that kind of process look like, and who provides it?
So in terms of healthcare and GP registration, there's a couple of groups of patients here. So if they're planned liberations, then we will work closely with the community healthcare teams to ensure that through care is there, so that they can access and kind of have continuity of care around mental health, substance misuse, and actually have a GP to go back to. Part of the issues that we have are around if they don't have a permanent address to go back to, it makes GP registration difficult. But certainly within Tayside, we're working very closely with our primary care services to see how we can support that further. I can't comment in terms of the work that the through care officers to do, but where we can, we will work closely with them to make sure that through care is supported for all the healthcare needs of the individuals. I think where we come into challenges are when people are liberated direct from court, and we don't know that they're being liberated. So that makes the through care very, very difficult for us.
Would that happen if they'd been on remand, for example, and then got to court and they get released? Yeah. Right, okay. And how long would you typically be engaged with the ex-offender beyond release? We
wouldn't, in terms of post-release. What we could do, and what we do sometimes do, is where there are complex health needs as we will liaise with kind of key individuals within the community to make sure that key information is passed on, because we don't have the clinical IT to support that through care.
And I'm assuming that the effectiveness of that process could have a big impact on reoffending rates. I think you kind of touched on that earlier. So do you think there's improvements there that can be made that would have an impact on that? And is there any data, and I think you said that there wasn't any data on reoffending that we could really use here to guide that?
We, since 2015, we introduced through care support officers across establishments in Scotland, and they focus mainly on our short-term population, so not the statutory cases. And what they do is they support those individuals who agree to work with them to prepare for release. And as Gillian said, one of the biggest barriers can be access to housing. And if someone doesn't have an address, and if they don't have an address, if they're no fixed abode, then generally, although we work with housing providers and we're doing work with right across Scotland with housing providers to support individuals leaving custody, if they don't have housing provision, then it can be very difficult for them to identify any kind of accommodation for them on release. And very often it is the day of release. But what the through care support officers will do is ensure that all of the appointments that they have, so the appointment with housing, appointment for benefits, appointment for the GP, they will go along with them and make sure that they are supported during those appointments to get the best possible outcomes for them. They will then continue to work with them for, I think it's, we increased it from 3 months, no, it's 3 months now, sorry. They'll work with them for up to 3 months after release in order to be able to ensure that they are in a stable environment, because these are individuals who can be very challenging. And we know that we have occasions where they do fall out with people, they can become aggressive at appointments, and so the through care support officers will continue to work with them in order to overcome as many of those difficulties as they possibly can.
Is that support having an impact on reoffending rates? Are you able to comment on that?
Because it only was introduced across Scotland in 2015, it's too early for us to say that.
Okay. Final point, I'm going to have a go at the IT stuff as well, since everybody else has. Just to be clear on this, that the GPs have got a system that they use to access medical records, and is that, can different GPs access a different medical record from other GPs, or they've only got the access to their own specific data set? Is that how it works?
So the GP vision that's in prison health care covers all establishments. So where patients are transferred between establishments, they can, that patient journey is reflected on vision. When they go back into the community, that's where it stops.
You can't access the GP records and they can't access your records. And is that a technical issue or is that a procedural issue?
It's a system issue. I don't know if you want to, it's a system issue because they're two different vision systems.
Right. It's a bit of both. I mean, technically it can't happen. And that, there lies the problem in terms of engagement. And it's not fit for purpose.
Yeah, okay, thanks.
We can put a man on the moon, but we can't do this apparently. But anyway. Okay, just a couple of final points. One was on budget. On the table that we have, it says that if you're in Shotts, there's £2,455 spent per prisoner. If you're in HMP Grampian, it's 6,000. Any idea why there's that disparity? No. Would you prefer to be in Grampian with a health problem or Shotts? I suppose that.
And your numbers of prisoners that are in the establishment and the sizes of the establishments are going to be different.
There's a wide variation. I mean, it's for 2,500 right up to 6,000 and everything in between. Seems to be quite a variety. Yeah.
Just when we were pulling that information together from a Greater Glasgow and Clyde perspective, actually we really struggled with the question, because the way in which we were answering the question is it's kind of a false picture. So taking the number of prisoners and the budget you've got and dividing it takes no account of some prisoners will be extremely complex and require lots of healthcare input. And in actual fact, if you were able to quantify that and had much more detailed information, you would see quite a disparity in the cost depending on the presentation that you have to deal with. So in some respects, it's historic and it's associated with what was available at the point of transfer with uplifts over each of the 5 years. And in other respects, it's not a true reflection, it's simply a mathematical exercise, and the actual picture for a prisoner or patient might look quite different depending on their presenting needs.
If only we had an IT system that could quantify those costs. The final thing was in relation to healthcare complaints. If we look at the table we've been provided, these seem to have increased dramatically over the 5-year period. Is there any panel get any view on why that would be?
I can perhaps say a little bit from the perspective of the independent prison monitors who deal with a large proportion of complaints in relation to healthcare. And I think it's safe to say that often when monitors look into matters, there's not been anything happened wrong in terms of kind of clinical decisions or policy not being followed, but what often is missing is that point about communication. So the extent to which people feel involved in or informed about decisions and about plans for their care. So often
that's not what it says here. The most common reasons for complaints tended to be around treatment received, waiting times, staff conduct and medication.
Yeah, absolutely. So if you take, for instance, medication or waiting times, often part of the issue is people don't feel that they've got clear information, for instance, about how long they're going to have to wait for an appointment. It's not necessarily that the waiting time is out with that, what you'd see in the community. The problem is people don't know how long they're going to have to wait. Similarly with medication.
They're not told.
Often they're not. Or they certainly haven't received that information.
Okay.
If I could say, yeah. I would echo Beth's comments, and having recognised that communication is an issue, it's about expectation. So we are trying very hard across prison healthcare to be much clearer about what patients can expect from the healthcare provision. So trying to provide literature, information face-to-face in lots of different ways around, for example, dental care, what you're likely to have to wait before you have an appointment for a routine dental inquiry. Medication, what you can expect, what we ask of you as an individual in relation to the more information, recognising the more information we provide up front, the easier it is for patients to understand what they can expect from us, in the hope that that promotes a dialogue as opposed to a complaint if something is not going the way they've expected.
If the waiting time for whatever is 2 weeks, and the complaint comes in and says, I've waited 2 days and I've not had that, that's not a complaint.
Well, there's been a fair bit of debate and communication between ourselves and the Ombudsman around how we handle those issues. And there is a hope or an aspiration that with the new complaints procedure being introduced from the 1st of April and a greater emphasis on and a greater length of time on the ability to resolve issues informally, the hope is that that will have an impact, A, on the number of complaints, but B, on communication generally and expectation generally.
Okay, time's beating us, I'm afraid. Yes, final thing. John, I wonder if you could help us and provide some additional information to the committee. If there's any work that your organisation has done and made recommendations that have not been implemented, or indeed that have been implemented, it would be good to hear what work has been done that has been followed through and any that hasn't been followed through. I think that would be helpful information for the committee if you could provide that. We are finishing this inquiry very soon, so the end of next week, so you need to send us that.
By the end of next week?
If you can. Sorry about that.
That's okay, Neil.
Could I thank all the panel for their attendance this morning, and can I suspend briefly till we change the panel? Thank you. We're going to continue our work on healthcare in prisons. Can I welcome to the committee Aileen Campbell, Minister for Public Health and Sport, Daniel Kleinberg, Head of Health Improvement, and Professor Sir Lewis Ritchie, Advisor Public Health, all Scottish Government. Minister, would you like to make a brief opening statement?
Thank you, Convener. And I want to start by thanking the committee and offering some very brief opening and introductory remarks. The first thing to say is the aspiration to parity and consistency of care in prison and the community is something that unites everyone who is concerned with prisoner healthcare. It is, however, important not to lose sight of the fact that the prison population is already very different from the general population precisely because they come from some of the most vulnerable parts of our communities. That means that many of the people most at risk of offending and being deprived of their liberty already come from places in our society where the rates of ill health are unfortunately very high. Similarly, the impacts of poverty, addiction and mental and physical disease run at much greater rates than the average. David Strang, HM Chief Inspector of Prisons, makes the point in his submission, many have poor health before they are sentenced to a term of imprisonment, and this can be exacerbated by a period of incarceration. And this isn't to suggest that we can be complacent. It is to reflect that just like the general population, the prevention of some of the poor health prisoners are produced over lifetimes by the environments that they have come from. However good our healthcare is, in the community or prison, those inequalities need to be addressed beyond treatment in isolation. And in the general population and prison population, the effects of those are long-lasting and complex. And that's why since April 2013 we've invested in £296 million to mitigate the effects of welfare reforms, and it's also why public health measures focused on the most deprived communities, smoking cessation and minimum unit pricing, will be disproportionately important. Turning directly to the provision of healthcare in prisons, I want to start by thanking the staff from the NHS, partners and the SPS who work hard day in, day out to support prisoners and their families. There is a frustration that since the transfer of responsibilities to the NHS that progress has felt slow, but almost all of those involved recognise that there has been progress in parts, and an aspiration to see more consistency in provision is a common theme among those who work in a hugely challenging environment. The partnership working that Macmillan has entered into with the SPS, NHS and local authority to support the palliative care needs of prisoners is a good example of what is possible, as is of the work on dementia that Alzheimer's Scotland has done in shots. There's always more to do, but the extension of waiting time standards to drug or alcohol treatments in prison setting has been a real positive and an example of seeking to make an offer that meets the standards outside the prison walls. In prisons, 1,136 people started their first drug or alcohol treatment between October and December last year, with 96.8% waiting 3 weeks or less. That sits alongside local work on recovery in individual prisons, which is hugely beneficial. It's also important to keep sight of the structures that are there, even if we need to increase the traction. Prison healthcare is the responsibility of integrated joint boards, and Healthcare Improvement Scotland provides the health input to the inspection of prisons by Her Majesty Inspectorate of Prisons. Where recommendations are made in those inspections, local boards will work with the prison authorities to meet the required standards and levels of care. And I share the analysis of some of the challenges that we and partners have going forward. Better data collection and a move towards consistency of care are something that we all want to see, and will seek to deliver against a challenging backdrop and inherited legacy systems. Ensuring prisoners and staff are safe is a critical part of the prison care, and that means some general things like transport and specific things like needle exchange can't just be overcome easily. I believe that the collection of data and partnership working on access to services needs to be the front and centre of the forthcoming work programme of local partners and the National Prisoner Healthcare Network. NHS standards for healthcare provision of primary care apply to the provision of care within the prison setting 24 hours a day. And Sir Lewis Ritchie's report, Pulling Together, Transforming Urgent Care for the People of Scotland, published in November 2015, acknowledges that more work needs to be done to improve the resilience of out-of-hours services for prisoners, particularly around electronic national record linkage and quality assurance of service delivered across Scottish prisons. Work is already underway that will ensure that the clinicians who are working in prisons will have access to the information in the healthcare IT system for people in police custody. Up until now, that has been a gap in data access. Building on this, access to data and data linkages are being explored further as part of the report's implementation. And similarly, we know that many people have poor mental health before they are sentenced to a term of imprisonment. We know that if we get it right, or at least better, for those with mental health issues who come into contact with the justice system, the benefits will be felt across communities in terms of longer, healthier lives, reduced reoffending and reduced victimisation. And we expect the next mental health strategy, due for publication imminently, to give renewed impetus to working collaboratively on the issue of prisoner mental health. To strengthen the drive for change, improving our response to mental health in justice settings is a key priority for the Justice Strategy for Scotland, which is also presently being refreshed. I'm glad to see the SPS taking on the commitment to make prisons smoke-free in the next 5 years for the sake of prisoners and staff, and for my part that means an ongoing focus on cessation resources in areas and communities of greatest need and deprivation. So finally, I want to conclude by looking back to my opening comments about the environment and the wider context from which prisoners come. Prisoners often have young families as well as treatment within prison walls. The support we are giving to the expansion of prisoners' visitor centres to support families is also hugely important. We've worked to move away from short sentences and the unnecessary use of remand because the deprivation of liberty is rightly a last resort. It is encouraging that Scotland's average daily prison population is the lowest it has been for a decade. All of these are important moves to try and adjust the use of prison to be as supportive of rehabilitation as possible. So again, thank the committee for their interest and happy to answer any questions.
Thank you. We are very, very tight for time, so short questions and answers would be appreciated. Donald.
Thank you, and thank you to the panel for coming. In the evidence session that we've just had, Teresa Medhurst, who's the Director of Strategy at the Scottish Prison Service, made, I think, a quite startling admission around social care and who's responsible for that in prisons. And she said that the prison service weren't included in the legislation around integration, that it was categorically not the NHS who were responsible, and she was unclear as to where responsibility lay. Given we have an ageing population in our prisons, and in the world of integrated health and social care, do you recognise that there is a gap here? And if so, what is the government doing to identify who is responsible?
I think as well, I think it's fair to say that across a whole host of the issues that you've been looking at and that we've heard from your panel today and the panel previously, that despite the improvements that have been made, there is still room for further and greater improvement and for the pace to be improved as well. In terms of social care, it's the prison service that are responsible for social care, and that's where we would expect them to take the lead on that, and will be enhanced by the fact that they have the integrated joint boards as well as part of the structures that support social care provision across the country. I understand that SPS have recently completed a review of social care provision across the prison estate as well, and there's also the national care standards which have to be adhered to by the prison services as well, and inspected by the HMP Inspectorate for Prisons, assisted by the Care Inspectorate. So there is a regime there and a structure in place. Whether there is improvements to be made, I would imagine there is in all areas of healthcare and social care across the prison estate, but certainly in terms of leadership around this, it's the prison service that are responsible for social care.
In relation to that, the organisation Families Outside, and this is in regard to the new national standards that you referred to, said that whilst they make a welcome recognition of the issue of social care for prisoners, many of the standards fail to apply to the care of people in prison. So I think my question is, what steps have been taken to ensure that they do apply? Because it's obviously important that they must apply.
Absolutely, and we will continue to work with partners across the piece as well to make the improvements that are necessary in light of the comments that you've had, but also, again, it's there's a collaborative partnership working that has to go across the health and social care partnerships, and there is advice that has come from the Care Inspectorate that goes to the Her Majesty Inspectorate of Prisons as well, which will go towards the regulation and the scrutiny of that process as well. So again, we've got the structures in place, we've got a regulatory and the inspection regime in place, and together, those things together will help move and motor forward improvements on social care.
Could I just pick up on something there? You said it's SPS that's responsible for social care. Would it surprise you that the Director of Strategy and Innovation for the Scottish Prison Service told us in the previous session that she is unaware who is responsible for social care, or it's not clear who's responsible?
Well, the SPS currently pays for social care services to prisoners who require care.
So there's absolute clarity that it's SPS who's responsible for this?
Well, if there is a feeling that there isn't, we'll again continue to work. But you know, what we have is the SPS currently pay for social care services.
They're either responsible or they're not. There's no any. Is there any dubiety about whether they're responsible?
No, there's no dubiety.
Colin.
Point then, the memorandum of understanding at the moment is between the prison service and health boards. It doesn't seem to include integrated joint boards. So why do we have a situation where health boards are responsible for healthcare in prisons, but integrated joint boards aren't responsible for social care in prisons? Why is there a difference of approach between social care and healthcare? Well,
you're right, the landscape hasn't changed, and it's been a fundamental shift around, the biggest shift for the way in which health services are delivered with integration with health and social care since the inception of the NHS. And while prisons aren't part of that legislative change, there are very distinct needs that I think are rightly addressed by the prisons themselves around the complexity of the need and the complexity of the challenge that exists within the prison estate. So there is good reason for that not necessarily sitting within the legislation. However, partners in a collaborative sense are expected to work together to ensure that prisons get the services that they are entitled to, which includes healthcare and social care as well. I don't know, Daniel, do you want to further elaborate?
No, that's right. Prisons weren't left out of the Public Bodies Act. The legislation does focus on the delivery of the service. Health services are provided to prisoners on the same legal basis as the rest of the population, but in practice that means health boards have to work very closely with services to make services available when a person is physically present in the health board area. Because of the special circumstances of prisons, that obviously just means it's a different type of negotiation. So you can see that in practice it means buying the service in, and the prison service does that through third-party providers.
But I'm not clear why we made a change that health boards were responsible for healthcare in prisons. Why are the Scottish Prison Service still responsible for social care? Why did we not make that change when integration came into play?
I think, as the Minister said, it's a change that's come along since really integrated authorities came into play. So there's maybe a case for looking at how those things are operating in practice in local areas, but it's... And
I think as well, again, you know, the inspection regime and the way in which it's monitored will drive forward improvements, but also illustrate where there is further work possibly needing to be done. If that is something that seems to be considered a gap, we can refresh and look at that and reconsider that position. However, at the moment, the memorandum of understanding between the NHS and the prison service shows and illustrates the differences of responsibility between the two, with social care resting with the prison service and inspected by Her Majesty for Prisons, supported by the Care Inspectorate as well.
It's also uniquely work. I mean, it's a population which, as far as I can see, is nearly uniquely already accommodated, fed, and cared for within a prison environment. So quite a lot of the things that you would be attending to under care standards in the general population are already a feature of what it's required to do in a prison setting. And you also have security requirements over and above that, and very specific considerations, which mean bringing it into the generality, make it something that needs to be an ongoing negotiation, really.
So the government has a commitment, for example, to making sure that everyone who requires it has palliative care by 2021. Are you saying that arrangement means that the Scottish Prison Service will be responsible for delivering and ensuring that palliative care is available to everyone within the prison service, which will be a growing demand, and you're happy that the prison service is in a position to make sure that type of commitment, for example, will be delivered?
Well, there's already good practice around palliative care already with the partnership that we see between the prison service and Macmillan as well, and of course bringing in other partners, whether that's the local authority or the NHS more generally, on palliative care standards. So that precisely illustrates where good collaboration across a number of disciplines, a number of professions, a number of boundaries exist to drive forward the standards of care for that ageing demographic and those prisoners within the prison estate that have conditions that will require that support.
Marie?
Thank you, Convener. I wanted to ask about IT. So it was an issue that came up pretty much across the board with everyone that we spoke to, that the vision system that's used in prisons is unique to prisons, and it doesn't connect with the vision system used by GPs. And the GP vision system is being rescoped at the moment, and the prison system is outside of that. I can understand that in a way because it's clear that the prison system does need electronic prescribing and administration, but I just wanted to check that that is being looked at somewhere going forward.
Absolutely, and I think that's been very clear theme throughout all of your deliberations, the different people who have come to your panel, whether it was today or your previous one, probably no doubt been an issue that's raised with your own engagement as a committee with the different stakeholders involved in this. And there is a clear issue that we need to address, and that's why we have the Government e-Health Division has commissioned further analysis into establishing more functionality into the system. What technical requirements are needed for the prison vision system, and there will be work ongoing with recommendations to follow from that, which will also include around e-prescribing as well. Thank you. So while it's an issue that's been identified causing a challenge, I think the work that we've taken to address that will allow us to make significant improvements, because it seems to be a number of the issues that crop up. The key component has been around data, the collection of data, and the inability to do some of those things in a timely way and an efficient way. So this will unpick and unlock an awful lot of the challenges, I think, that are there. Lewis, would you?
Clearly, IT development is something that is compelling, not only for the prison sector, but also clearly for all systems in Scotland in the healthcare setting. When I conducted my DeVos review 18 months ago, it was published 16 months ago, in fact, we produced a number of recommendations, and one of which clearly was to try to unleash the considerable potential of electronic records, which we still have yet to do. And in order to move this on, one of the things that I am currently doing with colleagues is looking at how my report is being progressed in reality. There are 21 recommendations, and what we're currently doing is looking at progress. I'm also, I can't tell you that, sir, but there are encouraging yet. The actual progress report is likely to be available within the month. We're looking, I am encouraged by some progress, but clearly there's a lot still to be done, and I said so when I produced my recommendations. I said that some will come quickly and some will take much longer, particularly in relation to workforce issues. 11 out of the 28 were in relation to workforce development. And one of the principles we identified was that any development of services should be intelligence-led. I think that gets back to the point about the importance of data collection, electronic systems that can communicate more effectively, and us actually having the capacity to shape services with up-to-date information and intelligence to do just that.
From the previous panel, the impression that we got was that in terms of IT, that everybody knows this is a problem, has known it's been a problem for 5 years. Not a lot has happened, and that appears to be a lack of, if you like, implementation and leadership from above. So why have we not seen any movement on such a fundamental thing as, for example, being able to access patients' records, full records when they come in to the service? I mean, that's just a basic fundamental thing. So when can we expect a functioning IT system that talks to a GP system?
I think in the way that you articulate the issue, I guess that maybe belies, however, the complexity of some of this as well, and the sensitivities of this as well. And while we have addressed and identified that this is an issue, that's why we've commissioned, the government has commissioned this analysis and this research to look into the system to see what improvements we can make around functionality and around electronic prescribing and a whole host of other things to make the systems talk together more effectively, to make sure that that data sharing, that data collection can be done in a much more adequate sense. So that first bit of work is expected to be with us in May, and thereafter we can keep the committee informed about what practical improvements we can make going forward. But certainly the work has been commissioned to identify the gaps, identify where improvement, identify where we can increase and enhance functionality, where we can get that collection of data that's so important around how we can move the health of the prisoner population forward. And like I say, that I believe that's to be with us in May, and then we can keep you informed as the practical improvements can be rolled out.
Any prediction on a date when we might have a system?
Well, I'm giving you the date about when we're going to get the analysis of where the gaps are and what we need to do.
The analysis has been there for 5 years. I mean, people know it's been raised by the network and others.
I think it's that specificity and it's the functionality and it's a complicated issue, and I don't think anyone is under any illusion that probably it's not ideal for people who are working in that, if that's the kind of, if the system feels clunky, if it's not delivering what they want to do, if it's causing more if it's causing issues at the moment, then it's something we want to sort, and that's why the government has commissioned this work to identify what practical improvements we can make to enhance the system. That will be with us in May. We can then work out how we're going to roll out those practical improvements, and that's what I'm offering the committee, is to keep you informed as that work progresses. Any further issues?
I may add to that in terms of clearly urgent care services across the country, important optimal use of current systems is important. So consistent data sharing will be key to this. It will not just be about new systems, it will be about how best to use them. Yeah. And I think that also will be very important going forward.
Alison.
Thank you, Convener. The Royal College of Nursing comments that, and I quote, "Not unlike other services within Scotland's NHS, budget and workforce were seen as the main pressure points in terms of delivering healthcare in prisons. The demand for services in prison outstrips the resources available to fund and deliver care. And the British Dental Association notes that waiting lists have increased and the general oral health of the prison population isn't improving." Now, we heard from the earlier panel that there isn't a recognised model for a workforce model for healthcare in prisons. I wonder if you think that is something we need to address, and also how budgets and services can be, better directed to improve the health of the prison population.
Okay, on that first point, or that last point that you made, to address that first is, again, in my opening remarks, we talked around how the health inequalities we experience in society are much further magnified within the prison setting as well. So there is a need to tackle some of those very ingrained and deep-seated health inequalities in that prison population, which makes it complex and it makes it challenging and it can make it tricky. I think the shift towards ensuring that we can treat that within the health setting as opposed to it being where it was before, I think it's the right move, because then prisoners should be entitled and expect rightly to get that access to healthcare that they deserve and need, in the same way as if they weren't in within a prison setting. And for that reason, we expect then NHS boards to marshal the resources in an appropriate way to help cope with the health issues that are being experienced within the prison setting. We have, as a government, invested in our NHS. There is record investment in the NHS. There are greater numbers of people working within our NHS. That doesn't take away, though, from the fact that this is a challenging set of circumstances. There's a challenging fiscal backdrop towards making progress on some of that. But again, it's around working with the resources that we do have to make the improvements that we see and which prisoners expect as well. Around the model, one model or template, I think is also important to recognise that every single prison is very, very different as well. So perhaps it might not deliver the expected outcomes of improvement if you were to have a one-size-fits-all for all prisons. I don't know whether you can't really compare Cornton Vale with Peterhead, and that might make it more difficult to have a one single model for how you would configure your workforce. So for those reasons, I don't think that would be the best way forward around configuring our workforce. Nevertheless, I think the RCN is right to point to where improvements need to be made, and we're right, and our Chief Nursing Officer is working with her colleagues to work through the recommendations from the RCN report to make further improvements and to take forward some of the actions that came from that report. I don't know, would you want to?
Or maybe, well, if you'd like to.
It's worth saying that I sit within Health Improvement Division, which works in public health, so the most immediate contacts I have with this are around tobacco, alcohol and substance misuse, but also the wider health inequalities. When it comes to having a single workforce or a single template, we did an awful lot of work with the prison service and with the NHS and local health and social care partnerships to try and look at drug and alcohol waiting times and drug and alcohol treatment in prison. So it's a very challenging environment. I mean, the thing I took away from that is just how difficult a national standard or a national workforce is to apply in different areas. So when I looked at the committee's submissions, watching each individual health and social care partnership work through the needs of the prison population they've got is hugely important. So for us, it's a very different offering that we need to make within Polmont than it is within Perth. The nature of the men is different, and the nature of the treatment required and the nature of what recovery might look like can be very different. So on that, I'm not sure I could ever generate one workforce template for drug and alcohol treatment. I do think what it takes is clinical and professional judgment to be inputted into local understanding of those populations.
Sorry, you mentioned also dentists as well. Within that, there's going to be work this year done to survey the improvement in oral health following the NHS taking over responsibility for health care as well. So I think that will give us also more data and understanding of where further improvement needs to go. Lewis?
In terms of needs assessment, I think this is why you cannot have one size fitting all. What we discovered again in the round of urgent care, but also clearly applying to the prison service, was that basically we needed to skill up our workforce according to the needs of the population, which are changing. And clearly we've heard already today that the prison population is ageing. There are new needs appearing, like palliative care, and there's good work sponsored by Macmillan, supported by Macmillan on that. It's key that interagency collaboration of a very high order is required going forward. And the prison setting is a very good example of where that should and is happening.
If I may, Convener, I am aware we're tight for time, so I'd kind of like to try and ask two final questions. One, the papers that we have show that there are clearly differences in the budget per prisoner spent on healthcare, and the paper also shows that prisoner healthcare complaints have raised markedly between 2012 and 16. Here in Edinburgh in 2012 there were 37 complaints from HMP Edinburgh, and that's risen to 513. So I'd like to know if any work's been done on the correlation between the spend per prisoner and those complaints. And my final question, if I may, in the earlier panel, John Porter said that with regards to health inequalities, we've still not got the model right. Obviously, we'd like to see more emphasis put on prevention, and that would help reduce the number of people who find themselves in prison. When people are in prison, there's obviously an opportunity to tackle health inequalities, but we've heard from ex-prisoners, there was one who told us that managing to be clean for 8 months in prison came out and found himself with a needle in his arm within 48 hours. So I think a universal experience is the lack of through care and services when people leave. So if you could maybe address those questions around complaints and the need for better through care.
The complaints issue, prisoners do have, well, they've got the right to make sure that their voices are heard and that their concerns are known. Of course, we've also got the inspection regime there in place as well, and we've taken action to ensure that prisoners have equitable access to the NHS complaints procedures as well. So that's also followed from the shift to the NHS assuming responsibility for this. In terms of through care, I think probably we'd all we'd all appreciate there is more needing to be done. However, what we need to do as well is also making sure that our public services understand the vulnerabilities of the population at the point of liberation, are what they need in terms of support and how they get that support as well, and that the good work that often happens in a prison isn't undone through there being a lack of support once they are back in their own community. I think that's a frustration. That'll be a frustration probably felt by the prison service, more generally felt that all that good work is gone for naught if the person spirals back into the old habits. It's also the work that the Cabinet Secretaries leads as well in terms of tackling reoffending, because we want to make sure that the support's right as well, and that's why he chairs a group of ministers with a whole host of responsibilities around this, whether that's Kevin Stewart for housing, JB Hepburn and others in terms of employability, social security. It's why we need to get that holistic picture right, and why we need to make improvements again in terms of through care to ensure that those vulnerable individuals are given the support that they require. And there is statutory obligation for prisoners who have come out after 4 years to get that through care support as well. And there is a range of people and organisations and groups that are there to support prisoners as well. But again, I think some of the learning from your session shows that maybe that consistency isn't felt, and that's what we need to make sure happens in a better way.
Claire?
Thank you, Convener, and I'd like to refer members to my register of interests as a mental health nurse, because I want to ask a bit about mental health in prisons. And we know that proportionately prisoners tend to have more mental health issues or difficulties in the general population. We heard in the last session up to 70% of prisoners have a mental health difficulty. And so I'd like to know what sort of planning is going in place in terms of ensuring that prisoners have timely access to mental health services.
There is considerable effort, and I think that will be further enhanced as well through my work of my colleague Maureen Watt with her refreshed mental health strategy, alongside the work that the Justice colleagues are doing to refresh the Justice strategy as well, which I think will give sharper focus and allow for greater collaboration around improvements that need to be felt around mental health in terms of the prisoner population. I think, you know, in common with people outside of the prison, people have the right to expect adequate and timely input from the right mental health practitioners. Again, though, I think the further drive and the impetus that the mental health strategy will create will further drive improvements alongside that collaborative work that needs to happen alongside Justice colleagues as well.
Okay, anybody else want to? Miles?
Thank you, Convener. I wanted to touch upon issues around liberation, because I think this is something I've found quite interesting when we've met with professionals and prisoners to talk about reoffending, and actually how important liberation actually is within that, and potentially breaking that cycle. What would you see as the health expectations someone leaving prison should expect?
So somebody leaving, what responsibility do the health boards? Well, I suppose in terms of just some of the themes that we've spoken around, it would be adequate and transition for mental health support if that's required. There would be the continuation around the work around smoking cessation or drug dependency issues. You know, those things will then transfer to their local GP and as well through those records. And while we acknowledge that there is improvements to be made around data sharing, some of that work is transferred to their GP in their community setting, and they should then, when they're out of prison, expect the same help and adherence to the same targets and guidelines as anyone else, regardless of whether they have had a period in prison or not. Can you just
on the back of on some of the substance misuse work, for example, in the terrible story we heard earlier, quite often prison is the setting where you can stabilise somebody, but however good the through care outputs are, and they're variable, when they're out, they still want to have to attend. They still need to be able to get to their local groups or whatever harm reduction or recovery approach they want to take, and that's just very challenging. You're quite often dealing with people who have chaotic lifestyles and who don't necessarily want to engage with the authorities, having just been released. So That's partly why we've supported the provision of naloxone kits within prison, because these are risky times for individuals who are already living high-risk lifestyles.
I think that's where the evidence we've had shows the opportunities aren't really being realised there. So someone not necessarily being registered with a GP before they leave, someone not even having housing organised before they walk out, a sort of £70 to go and sort their life out is not really going to resolve anything. I think more importantly from people I spoke to was the option to potentially have a placement or accommodation away from their home community, because they knew themselves that they would be back into a peer group where reoffending was going to happen, like Alison Johnson mentioned, within hours, and that was just going to put them back. And that's something I think we really needed to see improvements made, that they wanted to be helped, but that certainly wasn't available currently.
Regard this as a form of anticipatory care planning. I think, again, I see that going forward in terms of transforming health services, a significant endeavour needs to be looked at in terms of trying to preempt things, trying to plan ahead, not just waiting for the crisis to happen, the opportunity to be missed. And this is, again, very important in relation to the prison population, but it's also true clearly of other vulnerable members in society as well, so that they can get the best service according to their need.
And I think in the same way that we, you know, the prison services liaise and bring together the support that's required around social care within the prison setting, so too would we expect that same holistic approach to be taken when somebody has left that prison setting. And that's why the Minister, Cabinet Secretary Michael Matheson, has convened this ministerial group on offender reoffending, because we've all got a stake in this as well, and that includes housing, it includes employability, it includes the mental health support that's required. So it is broader than just health. It's a bigger bit of work that requires many different players in many different disciplines, many different departments to come together and work and anticipating that vulnerability of somebody when they leave the prison setting, but so too when the prisoner is in the prison setting and the prison service are responding to the needs in terms of social care. They are taking that lead to bring together a whole host of different disciplines together to ensure that that prison gets that holistic support that they require.
Okay, Miles. A couple of things. The previous panel were at a loss to tell us who was the lead on this piece of work. So could you tell us who the lead civil servant is and who the lead minister is?
Well, I've just described how, on terms of reoffending, how there's a number of different ministers with a stake to play, because it doesn't neatly fit into one ministerial portfolio, unfortunately, and there is blurriness around the lines because people have, you know, my colleague Maureen Watt will have responsibility for mental health. I've got responsibility for public health. So there is a range of different cross-portfolio ministers which will have an interest in it. Of course, for health care within the prison setting, that will sit with the health department. I've outlined a number of ways in which we're looking to take the improvement
who are the two leads on
forward. Well, I'm
on
outlining
prison health care.
This sits within the health team. It
So
sits
is it
within
yourself?
Myself. Maureen Watt will take an interest around mental health, which is a huge part of this whole picture as well. So it's more than just one minister. It's a department, and it's cross-cutting at many other areas in terms of the through care. Is that the same for the civil service side? Well, I would expect that to be the case.
I think that's a problem. I think that's a problem because people kind of don't know who's feeding up, who they feed up the information to. It seems to be very much across the piece. The people in the previous panel didn't know who they were reporting to or who they were getting information
But there's
from.
also leadership at a local level that was required as well. It wasn't just around, rightly, we need to drive forward improvements in a national sense, and that's why we've commissioned work to analyse what a greater functionality we require around our IT systems, what more we need to do around through care. The Chief Nursing Officer is working through with her colleagues and through the prisoner healthcare network around what improvements we need to do in light of the RCN's report that they published last year. There's also the integrated joint boards, there's the health departments as well. So there's a collaborative approach that needs to be required, and there is absolutely a requirement for national leadership to drive forward the improvements within a prison setting as well. So it sits with us, healthcare sits with me and with the Cabinet Secretary and with Maureen Watt across the piece because of the complexity and need of the prison population. And of course that means that we have a civil service that has to work across portfolio, but I think that's actually something that is better than it just being sitting in one strict place without that collaborative work going across government. But we recognise the requirement to drive forward improvement, and that's why we'll work across portfolios and work across different departments to make sure that we get that done in a holistic sense, as well as doing that for through care and of the prisoners once they've been liberated.
Okay. Just a final thing. I think it may have been a slip of the tongue, but you mentioned Peterhead Prison, which did close in 2013, so it may have just been a wrong selection of, but we should put that on the record.
I apologise.
Okay. Thanks very much for the panel's attendance this morning, and we'll suspend briefly. Just in a moment, put the session with NHS governance on the record. Do you want to lead with that just before? Okay, item 3 is NHS governance. We had a session, informal evidence session this morning with NHS staff. And I put on the record my thanks to them for coming in this morning and speaking to us candidly. Would anyone like to open up and reflect on what we heard this morning?
Thank you, Convener. No, I found it a really interesting session this morning. I'd like to put on record my thanks to the staff who gave their time to come along today and talk with us. Just to start from a very sort of global point of view, one of the interesting things that I picked up was about staff being keen on having an NHS Scotland-wide governance strategy or guidance, because they felt that each health board had its own governance, and given that we're a small nation, that it should be an easy win to have a national framework.
Any other issues people want to put on the record? Miles, yeah.
I mean, one of the words which everyone I spoke to this morning kept coming back to is communication. I'm quite clear that communication within our health service has taken many steps backwards, and that's from whistleblowing right through to just people wanting to be able to feed into management their concerns and not feeling, firstly, the confidence that they could, but also that they would be acted upon. So some of the points raised specifically were around increasing levels of long-term sickness around this. And also, I think, for me, one of the key aspects of what I heard was actually management not ever actually linking in with staff. So people who have problems not actually knowing who their management are to take that to, but also the need for senior management to actually shadow staff and see what they're dealing with, and it not just being management looking after the beans, but actually understanding what people are facing at the coal face. And I think that's something which was quite disappointing to learn again, seems to be completely widespread across the health service.
Alison?
Yes, I got an impression of an organisation under a great deal of stress. I learned that they were working at 100% capacity all the time, with probably around 85% of the staff that they might need, and that lack of communication often came from a lack of time, that managers simply do not have time to manage properly and develop their own skills and expertise in that management. I also heard about a culture of under-reporting incidents because of fear of doing so and potential implications, and a lack of consultation too, even on something as simple as decisions around uniforms. That a move to one uniform fits all had led some to feel faceless, very much like they were numbers, and also a view that what they entered, what they believed to be a profession, and it's now very much turned into an incredibly hard job. Those are some of the points I picked up.
Anybody else?
Yeah,
Donald?
I would echo what Alison says. I mean, I did sense a lot of strain and stress in terms of what people said. There was also a word that was used which struck me, which was that there was this sort of defensive culture in the NHS. Everyone felt very defensive in terms of what they were doing. And I think that's probably something that we need to address.
Myself, I picked up a number of things, but the one thing that they all said at the end is, please ensure that your work makes a difference. So the work that we're doing makes some kind of difference. The majority of people said that they're under pressure like they've never felt before in their career in the NHS. All of them could identify the camaraderie, the solidarity that they have between each other in providing that healthcare, and they got great support from their colleagues on that. They also said that they often got letters or cards or whatever from patients who had been provided with very good care, but they rarely were told thank you with any sincerity by people up the tree in the management system, and that was quite a general theme that I heard from quite a few people. A number of them said that they don't know who senior managers are in the system. So even like the site director of a hospital, they didn't know who they were. Now I found that quite remarkable, that they didn't know who the person's name, and it's that didn't appear to be one or two people who maybe have had a grievance or a problem. That seemed to be a general theme. I did there's a number of concerns that are issues that I have written up, but one that really concerned me on the basis of things that's in the media yesterday and today about long hours was there was a junior doctor who told me that she had just came off 5 sessions, 5 shift patterns of 7 days on, 2 days off, on 11-hour shifts, 5 in a row of 7 on, 2 off. That to me is not healthy for patients or for her. And she mentioned that a number of her junior doctor colleagues had left either the country or the profession already because of the pressure they are under. That is quite concerning given what's in the media. And there's a whole range of issues around staff appraisals, around sickness absence and CPD, a whole range of issues, but we will ensure that those are captured and everybody else's points are captured in our report, and if those could be ensured we're forwarding them as soon as possible. Marie, sorry.
Can I just mention that one of the things that was raised with us was undoubtedly the stress associated with having to work at 100% all of the time, and that was certainly made clear that there was a culture of working overtime which was difficult for many of the staff. Some of the positives that were raised with us, and once or twice one of the people in our group commented that we seem to be talking entirely about the negatives and not mentioning the positives. So one of the positives that was mentioned, which we should get on record, was the much better multidisciplinary team working than there has been in the past, which is considered to be a very good, a real strength in terms of governance. Another positive was that although there is still the risk of CPD time being lost, it's the sort of the first thing to go, ago, if the system is under pressure, there was a perception that it was slightly better than it had been a couple of years ago. So there's probably been a slight improvement in that, and you know, they felt that CPD was being given a higher profile than it had been a couple of years ago.
One of the things a couple of the people said was that, which I didn't quite understand, but we can look into, is the way in which if sickness absence goes up, it eats into the budget for CPD. I couldn't quite understand how those two things were linked, but they were saying that, you know, if it goes up and up, then the budget for CPD goes down and down, which seems quite a strange way for things to operate. I don't know, did you hear that as well?
Yeah, I wasn't sure, again, kind of how that was budgeted for.
Yeah,
But one of the other aspects I just wanted to put in there was targets. Obviously there's work going on around that, but some of the people I spoke to specifically were quite open, saying that targets are being fiddled constantly, and a lot of that is just about trying to be able to say you've met a target when in fact in many cases they thought they were completely unachievable anyway. I think that was concerning, that there seemed to be this culture of trying to fiddle to chase a target instead of really looking at you know, the patient experience, and also what was an incredible resource of people who'd worked in the health service for, in some cases, 30 years, and just felt they were not being listened to at all.
Ivan, yes.
Yeah, just picking up on the point you made about management. I mean, I asked the folk who all worked in hospital, acute hospitals, what the kind of management structure above them looked like, and they sort of laughed at me because they couldn't even begin to describe it. They didn't know how many layers there were, or who was responsible for what, or who was in charge. So yeah, I can echo the point you made. There did seem to be a lack of clarity and transparency around who was responsible and who was managing the thing.
I think, to be fair to the many of the people who spoke to this morning were fair. They said that they don't particularly blame the people who are in the management level, because they're under immense pressure to deliver whatever they're being told to deliver, and the whole thing is that tension between the pressures that are on the system and that you know, the issue about what is being driven from the top, completely having no consultation with the people at the bottom about how that's implemented. And they were saying that they have many ideas about how to implement change, but don't know how you can ever implement that change because it's a top-down change rather than a bottom-up change. Although they did say that within their ward or within their section they can implement some change, but when they see bigger change that needs to happen, it's very difficult to influence what's happening at the top. That's kind of what I picked up. Marie?
One of the things that was raised in our group on the issue of change was that there just isn't enough room in the system at the moment to test change, and that naturally clinicians are very cautious about changing procedures because they don't want to move from a system that they know is effective to something which is new and might be less so. So there was a concern that it's not possible to test change because the system is currently at such a level of capacity. On the issue of targets, that came up in our group as well. We didn't hear, nobody mentioned fiddling targets. What we did hear was that targets were being adhered to almost without any possibility for clinical judgment. So there was, you know, the idea that this target, which may have been plucked out of the air, say 12 weeks for an operation or something like that, but you know, there was no room for clinical judgment from the individual clinician treating that patient, who could possibly have judged that that individual patient could wait longer or needed it sooner, and that the target was driving how the, you know, when the care was delivered rather than individual clinical judgment.
Okay.
Point that was made quite strongly by a couple of people, a reliance or a promotion of fixed term contracts and part-time posts even being offered to new graduates, which meant that when they came in and did a few hours, if they were asked to stay on for the rest of the day, then they wouldn't be paid overtime, they would just be paid time. And they felt that the use of both fixed term contracts and the part-time posts is all about avoiding offering permanent contracts with more expensive terms and conditions. And another issue that we were asked to look at was the number of consultant locum consultants who would not accept permanent posts but would work in a way which is incredibly expensive. So they did ask if the committee could possibly investigate that issue further.
Okay, if there are any other issues that people picked up on, can please feed them into committee clerks and we'll try and cover all that. Okay, as agreed at previous meeting, we'll now go into private session. Thank you.